So good evening, everyone. Nice to see a lot of familiar names back here again with the third part of the beautification series. Hopefully you've enjoyed the first two, so without further ado, let's make a start. If you do have any questions, kindly do save them towards the end because it keeps popping up on the screen and I don't want it to just break the flow of this whole presentation. So do ask the questions towards the end. So what will we cover in this webinar? So we'll talk about the aging processes. The theme is obviously very similar to all the webinars. We'll talk about the aging process very quickly in relation to what we're going to be covering today, the relevant anatomy and the injection techniques. And as I said, towards the end, we'll think about going through all the Q&As. So we're going to be talking about the periorbital region and the cheeks primarily. The nasolabial fold I will touch base on, and then we've got the perioral session in around 2 weeks' time, so I will cover it then. So just a little recap at the aging process, and we now know that this is a multi-level process. So it's not just a matter of we're aging due to sun exposure or stress or poor diet and sleep, and it's not just the skin that ages, it's a combination of all these things which causes aging on a multi-layered process. So we know we'll have aging at the bony level, the muscular level, and all the other layers too, including the fat pads. So we'll talk into a little bit more detail about the fat pads. So taking a look at the first layer, and this is obviously your periosteum, so your bony layer. Now, if you look at this image here on the screen, I'll try and get my pointer up if I can. Laser pointer, yeah, here we go. So if you have a look at the orbital rim here in a young person, I believe this is of 30 years of age, and here is of 60 years of age. So if we take a look at the periorbital region and in the midface, because that's what we're focusing on today, we can see that as we age, the superior medial and the inferior lateral aspect of the orbital rim begin to widen. Think of it like bony erosion, like a meander in the river. And this is due to the ocular attachments of the muscles in these areas. And then if we look at the maxillary area and the zygomatic region over here, we will see atrophy of the bone or bony resorption. And on a profile view, you will be able to see maxillary retrusion as well as mandibular retrusion too. So one thing to keep in mind, however, is the bigonial distance does not change. So that will be the distance from the corner of the jaw here to here. So this width tends to remain the same as we age. Now, I like to use this slide in multiple presentations because often we fail to pick the right layer to be injecting the products on. And if the analogy I like to give is if you think of the bone as a table and the skin as the tablecloth, then when somebody has lines, folds, or wrinkles in the face, should we be injecting them directly in the skin or just under the skin? No, we shouldn't. Okay, so we need to be injecting product deep onto the periosteum. Why? Because we're making that table bigger. Okay, so once the table gets bigger, then we can work out what we're going to be doing on the more superficial layers. So looking at fat distribution on this slide. So on the left-hand side, we can see a very youthful face over here, and we can see a more aged appearance here. Now, these fat pads, there's two main levels. So you're going to have a superficial, which is up above this mass, and then you're going to have your deep compartment too. Now, the superficial fat pads are very mobile, okay? So they're dynamic. They allow us to have facial expression. And then you have your deep fat pads, which are static, okay? So they tend to be adhered to periosteum, and they are static. And we'll have a look at what happens to each of these as we age. So if you look at this diagram here, you'll see on the left-hand side here, we've got the superficial fatty layer, and then on here, we've got the deep fat. Obviously, this is going to be beneath the muscles. Now, these are a list of all of the fat pads. Now, in a nutshell, the main three that you're going to be seeing in the superficial region will be the infraorbital, the superior medial cheek, and then the nasal labial. So these three in particular, you will see a lot of changes in the superficial layer. And we know this from cadaver dissection. Keep in mind, not every fat pad will atrophy, which means get smaller. The nasolabial superficial fat pad tends to hypertrophy as we age. So it gets bigger, and then we have a little shift inferior laterally as well, which obviously is why we tend to get our marionettes. And then we have your deep fat as well, which consists of your SOOF, which we'll be talking about later on, and then your deep lateral and medial cheek fat, and lower down, your buccal fat. Some of you may have seen this slide before in the previous webinar, where we're looking at the stepwise process of aging of the fat pads. Now, this is an image taken from a study that was done in 2013 by Juan Dina and his crew. And we can see that one of the first signs of aging or loss of volume in the fatty compartment is in the periorbital region. Now, this is why periorbital region is a very good focal point when we're trying to rejuvenate or beautify an aging face. And we can then see that the next couple of points that age on the face tend to be in the malar region. And as I've already said, that the superficial nasolabial fat tends to hypertrophy as we age. Now, this is where the anatomy gets a little bit more tricky, because there's a lot of conflicting information in the studies out there in the literature. Now, there's a reason why as we age, because of gravity, things go down, but they don't just drag down to, the fat, it doesn't migrate into your neck and so forth, because of retaining ligaments. So these retaining ligaments tend to hold the fatty compartments and the muscles in place. Now, some of you may think, what is a ligament? What are one of these retaining ligaments? Now, these ligaments are basically, they attach to periosteum, and then they work their way up superficially through the SMAS, they branch out, and then they adhere to the skin, the dermis. So you can think of the retaining ligaments like a tree. So it's quite thick beneath the SMAS, and as it goes more superiorly, it then branches out. And the whole aim of having retaining ligaments is to keep the more superficial compartments, the muscles, the skin, all in place. Now, as we age, what happens to the retaining ligaments? Now, not a lot of practitioners know this, but the retaining ligaments tend to collapse. And as they collapse, so if you think of it as a vertical wall, they tend to collapse towards the nose, i.e. medially of the face. So a little trick that I will tell you guys is, whenever you're injecting onto the periosteum, always try locate the retaining ligament and inject medial to this down onto periosteum. This way you will be able to provide more structure in the face. So just moving on and still talking about the topic of ligaments. Now, as I said, there is a lot of conflicting information in the literature as to what the ligaments are, their origins, and so forth. However, I felt this was a very nice diagram from a paper that was done by Wong et al. In 2012. And if you look at this diagram, what you'll see here is the tear trough ligament, okay? Now, as we come more laterally, this tear trough ligament then becomes these two ligaments over here, which is the orbicularis retaining ligament. This is your pre-zygomatic space, and these are your levator muscles and your zygomatic muscles, okay? So, in a nutshell, the tear trough will begin around the medial canthus, and then it works its way around laterally. And we'll talk about the importance of these retaining ligaments when doing tear trough rejuvenation. And so putting all of that into perspective, so we've got bony resorption, we've got atrophy of many of the fat pads. What is going to happen? Well, there's going to be asymmetry in the face. There's going to be a downwards descent and depression, and we're going to have disproportion. And some of you have seen this before, which is your famous triangle of beauty. And the whole point of what we're trying to portray with this image is to try and invert that triangle. So we're not trying to change the person to someone else, rather we are trying to invert it and make them a better version of themselves. So let's get down to the nitty-gritty. So periorbital beauty. So this is obviously going to be very subjective. So you've got 5 women here. You'll have, you know, the likes of Mila Kunis, Angelina Jolie, Margot Robbie, Scarlett Johansson, and Aishwarya Rai. So you can, if you have a focus in on the eyes, they vary in diameter, in height. The intercanthal distance is different amongst them. And if you even look at the scleral show, which is the white of the eye, okay, so you'll find that in the top right and in the bottom left, you can see more of the white of the eye. Now, seeing this sclera is normally associated with looking tired or looking, you know, dissatisfied. However, you can see that beauty is obviously still very subjective, and hopefully this portrays this. So what is the problem for us practitioners when we're looking at periorbital rejuvenation? So it is a very difficult area to treat, and it's quite challenging. Why is it challenging? Because there's so much variation in your bog standard tear trough. You know, so for example, here we do a lot of non-surgical rhinoplasty. You know, I'm going to speculate here, around 70 to 80% of people have your classic dorsal hump on the nose. And, you know, we more or less kind of know what we're doing. Same with the lips. A lot of people come in with just atrophied, shrunken lips, and we're just adding volume. But when we come to the tear trough, you've got absolutely so much variation. It's unbelievable. And the other thing is, when we focus on periorbital rejuvenation, it's important that we don't just look under the eye, because obviously, yep, that is your tear trough. That's the main point. But periorbital means also the surrounding structures, which includes the brow. It will include the temples, the frontalis, as well as the malar region. Okay, but it is a very important part of the face to treat. And as I showed you earlier on, one of the first signs of aging tends to be around the eyes. So that's where we see atrophy in the roof, so the retroorbicularis oculi fat, and the SOOF, so the suborbicularis oculi fat. Now, why is it a very powerful area to treat? Because emotion can be read through the eyes. So there's two parts of the face that I tend to look at when I'm examining a face and I'm formulating a treatment plan. And these are the lateral canthus and the oral commissure. So a downward pointing lateral canthus or a downward pointing oral commissure, these two signs are going to be associated with sadness and tiredness. Okay, so this is the whole point of trying to rejuvenate and create a lift in the face. Just going back to this slide very quickly, however, I did forget to mention, if you look at the brow position, remember it's periorbital, okay, so that means in focusing on the brow too, we will be able to see that the lateral brow has a nice lift. Now in some of these ladies here, it's slightly more elevated, and some it's slightly less. However, there is an elevation, okay? And more importantly, if you want to take this one step further, if you look at each of these women, and compare the medial canthus to the lateral canthus, you will find that the lateral canthus is slightly more superior than the medial canthus, typically around 10 to 15 degrees more. So a very important point to make here. So just going back onto track. So what do we do? What do we need to focus on when we're assessing the face? And given the periorbital region and the mid face takes a large chunk of the face, this is the classic and probably the most useful way to try and assess the face. This is your vertical fifths and your horizontal thirds. And especially here, if you look on the left-hand side, when you look at the vertical fifths, this distance, which is your intercanthal distance, should be the distance from the medial canthus to the lateral canthus, which then should be also the same distance from the lateral canthus to the peak of the zygoma or the lateral aspect of the face. Okay, now in some of those images that I showed you earlier on of those celebrities and stars, they don't exactly fit into either one of these. So that just goes to show that it's not one rule that fits all, but this is what we can just generalize amongst the general population. So what happens during the periorbital aging process? Now I did show you this earlier on, that there is a loss of bone or bony resorption, bony erosion, if you like, on the superior medial aspect and the inferior lateral aspect, where these two arrows are pointing. And if you take a look at this picture over here, so we've got a young skull, we've got an aged skull, and if you have a look over here, we've got the filler, as you can see, placed in the infraorbital region. And what does that do to the size and the shape of the audit? It makes it a little bit more circular and smaller again. Okay, so it's very important to know what's happening underneath the skin before we ever inject the skin. Some signs and symptoms or clinical features that we're going to be seeing in our patients will be dark circles, which is where product choice is very important. Genetics. Sometimes you'll even have kids or even babies that have a mild tear trough. Remember, the tear trough starts at the medial canthus, okay? So it could be a genetic problem, puffy eyelids. Some people are prone to puffy eyelids, especially waking up in the morning, malar festoons or malar edema, if you like, and skin laxity. So these things are all things that we need to consider and we may see in our patients. But remember, before all of this, we need to have just a quick think about what's happening at the deep layer, because a primary concept of rejuvenating the tear trough region is adding filler into the deepest compartment, which is your SOOF. So what are the boundaries of the infraorbital region? So remember the diagram I showed you earlier on. So superiorly, you're gonna have your orbicularis retaining ligament, as well as your tear trough ligament. Medially, you will have your buccomandibular ligament. Laterally, if you think of this logically, it's your zygomatic cutaneous ligament. And inferiorly, you're gonna have your muscles, so your zygomaticus minor and major. So just a very, I've got a couple of images quite similar to this, just to show you so we know the terminology, because that's very important before we inject. So let's take a look at this lady's face here. Now, she's got clear ptosis of the upper eyelid. You can see there's atrophy of the orbital fat. Why? Because there's a little bit of hollowing over here. I spoke briefly earlier on about the scleral show, which is the white of the eye. And this sometimes goes hand in hand with lid retraction, also known as ectropion. And you can see how this is going to give a very tired look. There's also brow ptosis. And more importantly, what we're looking at here is this is your nasojugular groove. And then lower down in here would be your mid-cheek groove. Okay, now there is a small bulge over here, which is your herniated infraorbital fat. And then slightly lower down over here, you're going to have your malar region. Okay, now another point coming onto the lateral canthus. Remember I said in those images I showed you earlier on about a very young, beautiful, youthful face. The lateral canthus is usually, typically in my eyes, around 10 to 15 degrees more superior compared to the medial canthus. But if you look at this image, the medial canthus and the lateral canthus are almost in line with each other. Or on this side, the lateral canthus is ever so slightly inferior. So you see how all these combining features give the impression of a very sad, tired appearance. Just as I said, a couple of images, just so we can get the terminology right. So here is your TTD, which is known as your tear trough deformity. Remember, it starts at the medial canthus over here, and then it will work its way laterally. And then as it passes the mid-pupillary line, we're going to have your palpebral malar groove. This is your nasojugular groove, and over here is your mid-cheek groove. Okay, so it's very important that we get our terminology right before injecting. And this is a more of a diagram for some of you if you couldn't see it very clearly in the two images that I've shown you. And again, you'll have your nasojugular groove, your mid-cheek groove, and then your palpebral malar groove over here. Superior to this is your infraorbital fat, which, well, the studies will say it herniates anteriorly and inferiorly as we age. So how do we classify the tear trough? And this is very important. You know, as with anything, especially a lot of us being clinicians, it's important to diagnose and classify before we treat. Now, this is a very popular classification. There's so many out there, but this is one that I like to use, which is a Hermann classification. And as you can see, quite simply, here it's mild, moderate, severe, or class 1, 2, and 3. And as I said earlier on, tear trough will start at the medial canthus, and then it works its way around. Now, if it stops short of the mid-pupillary line, it's grade 1. If it reaches the mid-pupillary line here, it's grade 2. And if it goes all the way around and becomes a palpable malar groove, then it's grade 3. So what are the concerns before the procedure? So And these are quite specific to periorbital rejuvenation here. So what type of filler are we going to use? Are we going to use something with a lot of G prime, with a lot of lifting capacity? Are we going to be using something soft? How much of the filler are we going to use? Do we inject beneath the muscle, the orbicularis oculi muscles? Do we go deep into the SUF? Or do we inject into the superficial fat compartment, which is the infraorbital fat? And then remember I showed you the ligaments. Do we go above the OCL or below, or even below the ZCL? And do we use a needle or cannula? That's a very common question I get asked, and I'm hoping somebody will ask me this later on, and we can talk through that together. So what is the approach to injecting the tear troughs? Well, the first point is know your anatomy and make sure you know where the infraorbital foramen is. Now, this typically is in the medial limbal line between 5 and 12 millimeters in a vertically line drawn downwards. So identify where the infraorbital foramen is, which in layman terms is a hole coming out the skull, and through the hole you have your nerve, artery, and vein. So a very dangerous point in the face, and we need to then decide where we're going to inject. And I will show you on an image how I've injected. The things we need to consider would be the medial and the lateral SUF. So remember, the SUF in the infraorbital region isn't all one layer, so to speak. Okay, so you have your medial aspect and then you have your lateral aspect. And if you inject product into the medial aspect, it will not spread into the lateral. So we need to be able to make sure that we are injecting both compartments. Think about injecting the temporal region. And if you remember to my first webinar where I talk about temporal rejuvenation, which will help elevate the lateral brow, it will also help elevate your lid, and it will also help elevate the lateral canthus, which we now know from what I've told you, that having a slightly higher lateral canthus is an element of beauty. And we will also then consider injecting the cheeks, which we'll talk about later on. So if you look at this image here on the screen, you'll see that this is a 6-point injection technique that I use for doing full periorbital rejuvenation. So the first point of injection for me is always here. I should have labeled these points, but oh well, so I'll talk you through them. So this is the first point, which as you can see is in the mid-papillary line. Okay, so we've got your tear trough, as you can see all the way around. It's in the mid-papillary line. Remember, in terms of grading, she is probably around a grade 2. So I would inject here, and I'm injecting deep onto the periosteum. Okay, so it's very important here that you inject in very small quantities and not too high G primer product. So the second injection will then be in the palpable malar groove, which is here laterally. Often I find people always focusing on the medial aspect and they forget the lateral aspect. So this is injection 1 in the mid-papillary line, and then we have injection 2. And then my third point of injection is back here at the medial aspect of the tear trough, again injecting with a needle down onto periosteum. Now it is a very high risk area given you've got the angular artery and the angular vein, and there's always anatomical variation and differences. So do keep anatomy in your mind, but once you're on periosteum, be sure to aspirate if you do, and inject very small quantities. Now, the angular artery and the vein are near the base or the junction between the nose and the face. So as you can see, this injection is still a fair distance away from that area. And once I've left a little bolus here, what I would do with my finger? I will massage the product medially. Okay, so just to recap, we've got point 1, we've got point 2, and point 3, and now we've got 3 more points. These are all bolus injections onto periosteum. So the fourth point then is going to be in the temporal region. So this is what we call Swift's point, which is from the temporal fusion line, which is around here. It's a centimeter up and a centimeter across, deep injection onto periosteum, and this will help elevate the lateral brow. If you are not very familiar with temporal injections and it's not something that you do, then what you can do is also inject a very small amount of bolus literally at the tail of the brow. And you're injecting it deep, so you're going to be in the roof, which is the retroorbicularis oculi fat. So you're going to be injecting onto periosteum. And then once you come out, a little trick is to hold the product where it's been injected and then push this up and hold it for a few seconds. And that way you're going to help stick the product to the layers, so to speak. So this is your fourth injection. Your fifth injection will be here. Now, as you can see here, from the medial canthus to the lateral canthus, it's ever so horizontal. Now, to get rid of this tired look or the sleepy look, what we can do is elevate this lateral canthus by injecting onto periosteum a small amount of product here, which will then help support the lateral canthus. So this is what we can call a non-surgical lateral canthoplasty. And my final injection will be in the malar region here, in the lateral zygoma, deep onto periosteum. You can inject something a little bit more thicker here and in a slightly more volume in order to provide structure and support. And this is immediately afterwards, okay? So very little bruising or bleeding, as you can see, and that's an immediately after result. And if you take a look at the lid, there's a little bit of heaviness over here, and you can see there's a slight reduction over here due to an injection in the temporal region. So just a couple of more images before and after. Here you can see quite a bad scenario of eye bags, and we can see straight after the treatment, and again you can see some differences here. So let's look at mid-face aging. So what happens slightly lower down in the face? So as we age, we lose the OG curve, which I'll show you what that is later on, but we lose the contours of the face. We have nasolabial folds that begin to fill, and we know that the superficial compartment, the fatty compartment in the nasolabial fold tends to hypertrophy, although not in all cases. Now, some of you may come across HIV patients which are on HAART drugs, medication, and what you'll find is they become extremely hollow, especially in the temples and in the mid-face. And it's such a classic appearance you have in these patients. So sometimes it's worthwhile in such patients to maybe use something slightly more different compared to just your bog standard HA. Maybe something like calcium hydroxyapatite may be a good option here too. So what is desirable? So we've got Kylie Jenner here on the left-hand side, and we've got Angelina Jolie. So you can see here, this is obviously a before picture and an after picture, quite a rounded face. And then she's obviously read the book of Aesthetic Principles, and we can see now she's got high arched cheekbones, a chiseled jawline, pointy chin, a really contoured nose compared to before, and a highly elevated brow. And you can see that the lateral canthus is even more higher compared to the medial canthus, especially when looking at the before picture. And the same principles would apply here in Angelina Jolie's case. Now, a lot of us will talk about her jawline, and I will talk about the lower third in the next webinar, that it's quite square-like and it's quite masculine. But remember, not everybody fits that rule of aesthetic proportions. And I'm sure many of you will argue that she still looks very beautiful. So moving on from those images, let's look at Cameron Diaz. And we can see, if you take a very good look at her cheeks. So this is before, and this is afterwards. So there's some form of implant into the mid-face, whether it's fillers, whether it's fat, whether it's implants, who knows? But the chances are whatever was injected is injected in the wrong place of the face. It's clearly injected very anteriorly, which is why now she's got the classic appearance of hamster cheeks. Okay, so sometimes it's very important that we know where we're injecting. So looking at this picture, chances are she's been injected quite superficial in the superficial fatty compartment and too much product in the anterior region, hence the whole hamster look appearance. So this is very important when it comes to rejuvenating the mid-face, and I will always say this is, it's not just about getting rid of the darkness or the shadows in the face. Sometimes we need to chase the darkness and the shadows. So what I mean by that is, once light reflects on the face, what will you have if you have a light reflex? Well, you're going to have some form of shadow somewhere. Now, the cheeks is a very classic example. If you create high arched cheekbones, what will you have underneath in the inferior aspect? You will have submalar hollowing, which is your shadow. Now, this is where women often put their contour in the mid-face. So remember, we are trying to create lights and shadows in the face, as well as the obvious, which is proportion, harmony, and symmetry. So male versus female considerations. Now, in the female face, many of you will probably already know this, that we tend to prefer to create high arch cheekbones. So you get this nice V-shaped tapered look to the face, and it's very contoured with some submalar hollowing. Looking at the male face, however, yes, there's still an element of submalar hollowing. This is often masked with facial hair. However, the lines in the face are a lot more vertical and horizontal. So we need to make sure that whenever we inject a male face, we don't inject too superiorly or too laterally, because we will end up feminizing the face. And I find that a lot of male patients tend to lose volume in the anterior aspect of the face, and that's where I tend to focus the injections. Whereas in the female face, it tends to be more superior laterally. This is very important for everyone to keep in mind, and that, as I said earlier on, beauty is very subjective, and we need to keep in mind that we see people from all walks of life, from all over the world. Now, I talked very briefly about submalar hollowing, so having some really nice high arch cheekbones, a little bit of contoured or shadowed look underneath. Now, this is very desirable in the Western world, where I am, or in the States, etc. But if you do this to somebody from the Far East, it's actually undesirable, and it may be even a sign of poverty, or being associated with being poor. So keep in mind that we need to take into consideration the ethnic background of our patients. I did very briefly mention the OG curve, and this is what it is. So again, this is just trying to make beauty a little bit more objective rather than subjective. And you can see in a young face, we've got this nice S-like silhouette feature where we see the prominence of the cheek, and then it goes in slightly, which is your submalar region, and then we've got a nice pointy chin. And obviously, as we age, this does tend to flatten out. So this is what we are trying to recreate, which is why the focus in a female face, or should I say trying to feminize any face, tends to be more superior laterally. It's always a good idea with your patients to make them smile when you're assessing them, because if they have good anterior projection on expression, then it would mean that we don't need to overfill and we can fill elsewhere. So the approach to injecting the mid-face, now this is what we call Swift's point, or the beautification point of the face. Now this is a line drawn from the lateral canthus vertically down the face, and then another line drawn from the superior alar crease to the upper tragus. Now where this point meets tends to be what we call the apex of the cheeks, or the beautification point. So a single bolus in this injection, typically between 0.1 to 0.3 mil, is enough to try and create what we can see here, a light reflex with a shadow underneath. And this is probably the more common type of injection method, which is Hinderer's lines, which is essentially a line drawn from the lateral canthus to the oral commissure, and then the mid-alar to the mid-tragal line here. Now, the importance of the alar tragal line is any injection that you do above this line in this region, you're safe to go down onto bone and inject with a needle. Any injection that you do inferior to this line, you tend to be a little bit more superficial. And we need to worry about certain structures like the facial artery, as well as the facial vein. Now, if you're going to be augmenting the cheeks, a very common injection technique would be to inject onto periosteum in this region with your needle. So you could do a bolus, bolus, bolus. Whether you do 2 or just 1 or 5 is irrelevant, but you can inject onto periosteum. And then what you can do is inject more superficially with a cannula, so with a 25 gauge cannula. So now not only are you injecting product onto periosteum, but you're also injecting product into the superior compartment. So once it's on periosteum, you'll be in the deep fatty compartment, and then above the muscle, you'll be in the superficial fatty compartment. So you'll remember what I said earlier on, is that we tend to see atrophy in both of these compartments as we age. So that will be the way to rejuvenate the face, and it's something we call the sandwich technique. So what are the anatomical dangers in the face? Now, I briefly spoke about this region here, which is an infraorbital foramen. Now, in most patients, around 75 to 85% of them, it's in the medial limbal line. In the remainder, it tends to be in the mid-perioral line. So these are things that we need to keep in mind, especially injecting the periorbital region, which is a very vascular region. I'm not going to talk too much about complications because I'll have a webinar which is purely dedicated to complication management. Now, facial artery and the angular artery are obviously very important. We know that the facial artery is anterior to the masseter, typically around 1 centimeter or so, and it's very deep, and then it runs up quite close to the nasolabial fold. At the level of the modiolus, which is the oral commissure, we know the facial artery begins to take off like an aeroplane. So we need to be very careful injecting the nasolabial fold, and then we also have the facial vein. Now, some of you may wonder, how do I inject the nasolabial fold? Well, many years ago, you see a line in the face, you stick the needle in, and then you just do a linear thread. Now, what I tend to do is I ask the patients when they're coming in, what do they often do? I want these filling, I want these sorting out. So then I ask them the question, now, which is the worst part of the line? And often they'll say to you, it's the superior pole of the nasolabial fold. So at the end of the evening, once they come back home, guess where the makeup tends to sit in the face? In this area next to the ala of the nose. So what can we do now? Well, we inject deep into periosteum with piriform fossa, and we can create an immediate lift with as little as 0.2 mil of a very high G prime product. And my injection method when it comes to injecting the nasolabial fold is in a very 45-degree manner deep onto periosteum. So that does bring me to the end of this webinar, everyone. So hopefully that was useful, and I'm sure some of you will have some questions indeed. So feel free to now ask as many questions as you like. I've already got a question here from Lazarus, who's asking, what is the amount of filler that's used in all 6 injection points? Well, this can vary. Now, typically I would use 1 syringe across all 6 injection points on that part of the face, and then you would need to use a 2nd syringe elsewhere. But typically most injections in the infraorbital region tend to be 0.1, 0.1, 0.1, 0.05 for the lateral canthus lift, and the temporal region you can go typically 0.5 mil, and in the lateral zygoma tends to be between 0.2 and 0.3 mil. All right, so do fire the questions through. Hi, Jocelyn from California. Hopefully that was useful to you as well. Somebody is asking for the link to the YouTube channel. This will be on the Facebook page, so please follow these links that you can see on the screen, which are on both Facebook and Instagram. Hi from Rhodes in Greece. So lots of thank yous coming in. I'm not going to read them all out, but I'm very grateful. Again, do ask as many questions as you like. So probably hang around for the next 15 or so minutes. So try and make the most of it if you guys have any questions. Kathy's asking, how do you locate the ligaments when injecting? I think that's just a matter of learning your anatomy at the end of the day. So, you don't need to learn where all the ligaments are of the face, but it does help. But especially for mid-face and periorbital rejuvenation, I think knowing where the orbicularis retaining ligament and where the zygomatic cutaneous ligaments are, because what you'll find is the orbicularis retaining ligament is what we call a true osteocutaneous ligament. It starts at periosteum and then it works its way up to the skin. And we know that there's going to be an element of deflation in that ligament as we age. So sometimes it's useful to know where they are. Hi, Jenny. You're asking do you use a cannula for tear troughs or needle? So I will use either or. In that 6-point method, you can see it was needle. However, most of the time I will say that I will use a cannula. Now my entry point for the cannula is anywhere in the lateral region, and then I approach laterally, okay, and then I work my way immediately with the cannula. So I use a 25 gauge cannula, usually 40 millimeters in length, and the injection plane is going to be deep. So you're beneath the muscle, you're in the SUF. Hi, Sherelle from Nottingham, I'm guessing. What's your products of choice for the mid-face? So recently I have been using quite a lot of the Luminera range, and they've got a product called Ultra Deep, which you'll have 1.25 mil in the syringe. So, you know, you've got a lot more to play with there, and I mean, effectively do both sides of the face, especially when focusing in the periorbital region, because you do want a very deep product. But yeah, for mid-face, you want something with a very high G prime. Hi, Agnieszka. When using cannula, are you superficial? Um, it depends. So if they have severe hollows, I will go deep on along periosteum, so I'm in the sooth. And then if you want to correct the icing on the cakes, so to speak, then I will bring the cannula out, and then I will inject into the superficial compartment, which is your infraorbital fat. Therefore, I'm superficial. So actually, with your cannula, you can go into 2 different layers with 1 entry point, which is very good. Slightly off topic, when correcting symmetry with Botox in the lips, can you show where you would inject the LLS? So the levator on the lips basically runs from the high aspect of the nose, and it works all the way around, and it attaches to the superior lip. So it's almost like doing a gummy smile. Botox, which is right next to the nostril, and it's a deep injection. So I tend to aim down to periosteum and just lift slightly and inject a very small amount of toxin, 2.5 units. Hi, Julia. Can you explain how to do a brow lift with filler? So let me try and get so you can see me actually. So with the filler, what you want to be doing is injecting into the lateral brow. So if you look at my eyebrow over here, you can see it's slightly high arch, and then the tail runs down. So what I would do is just beneath the peak of my brow, I would go onto periosteum with a needle and inject something like 0.05 to 0.1. And then once I'm done, I will hold the product and push this product up, and then just hold it there for about 10 seconds and then let go, and you will see a nice lift. If you combine that with injecting into the temples, you'll have an amazing result. Hi, Kathy. Can you please repeat the volumes in the 6-point lift? Okay, so remember there were 3 injections in the infraorbital region. So 0.1, 0.1, 0.1. And then just for underneath the lateral canthus, 0.05. And then the temples, 0.5 mil. And then you've got in the lateral cheek, which what you would typically do. So anywhere between 0.1 and 0.3 mil. Julia is asking, do you feel the upper hollow of the eyes? Yep, so that's what we call the A-frame deformity. Now, the A-frame deformity is probably one of the trickiest things to do in terms of the complications that you can achieve in that area. But I typically will then use a cannula, lateral entry point, and then I would feed the cannula through in the upper eyelid and just very gently do small linear threads, but a very small amount of product and not too high a G prime. So something that's very soft. Sometimes it's a good idea to inject a skin booster there. Although it's not cross-linked, you will have many benefits. So maybe a skin booster in the upper eyelid to potentially correct an A-frame deformity. But it is an area I will tend to stay away from with a needle. Hi, Anna. Can we use harmonica? Well, if you've got the CE approved magically, then yep, you can. But there's nothing. Once it's officially allowed to be used, I think harmonica will be a great product. It needs to be used by obviously experienced practitioners, given the periorbital region is a very high risk area. But places like say the temples or the cheeks, yep, you can still go on to periosteum with harmonica. Varon is asking, what is the filler for under the eyes? So something that's very soft. Okay, so Luminera have Gentle, which is a very soft product. And if you feel that they're very hollow and they need more of a lift, then you can inject something slightly higher G prime like the Luminera Deep. Keep in mind, under the eyes is one part of the face that you always want to undertreat. Okay, so I will always say I'm going to try and correct the tear trough around 70 to 80%, and let the time take its course. So always undertreat under the eyes rather than doing too much, because then you're more likely to be prone to edema or malar edema. You're welcome. I think I've got a few more private questions as well. Thanks for your time. Great webinars. You're welcome, Maria. Hi, Debbie. So is your preference needle for tear trough as opposed to cannula? Either or, 50-50. Cannula is what we can say slightly safer, but it's not foolproof. A lot of practitioners are using a cannula thinking that you are not going to have a vascular occlusion or any other complication, but you can equally have a complication with a cannula. But if you want to be slightly safer, then yes, a lateral approach with a cannula is going to be ideal. Hi, Peristina. You're asking what filler do you recommend for dark circles? Now, I think first we need to decide what is the reasoning for the dark circles. Is it part of the aging process? Is it a hereditary process? Do we need to use fillers? Do we need to use a skin booster? And obviously, if it is dark circles, then it tends to be a skin booster that is used because of the amino acids and the antioxidants to help target the pigmentation, rather than using a filler per se. But if they have a true hollow, sometimes it gives the appearance of having dark circles. So always try lift the hollows up first and then work on the more superficial layer. Sometimes another little trick is to get the filler and blend this even with a very small amount of Botox, and get a cannula and then feed this through in the superficial layer, and that will help try soften any fine lines and wrinkles without causing ectropion. Hi, Kathy again. Is the brow lift injection deep onto the bone? Yes, always deep. Always deep. We know that we're going to be very safe laterally on the superior lateral orbital rim, so always inject deep onto periosteum with a needle, with a cannula, that's fine. Anatomically, what you're trying to refill is the roof, which is the retrorbicularis oculi fat. Any more questions, guys? All right, I'm just going to stop the live recording for the YouTube, and then we'll carry on with the questions.